Hi, everyone, and welcome to another episode of Diabetes and PAD. Diabetes is a major risk factor for blocked arteries in mainly the legs, known as peripheral artery disease. It's poor circulation in the legs, and left undiagnosed, untreated, can lead to advanced stage critical limb ischemia, where your limb is at risk of amputation. So it's really important that we're always talking about these two issues because they relate. But it really comes down to, I mean, overall, it's getting control of the diabetes first so that you never get PAD. It's something that Mark Brezell, my co host for Diabetes and PAD, has been very successful at with his diagnosis of as first type 2 diabetic, right, Mark? And then it went
Briefly.
into type 1. And you share your journey in this book, which everyone should pick up on Matter of the Heart. But because you were able to really take the bull by the horns
Mhm.
and actually create the change you wanted to see with it, your A1C has remained below a 6, which
Mhm.
is huge, which really does lower your risk of peripheral artery disease and even more cardiovascular disease as well.
Mhm. Yes, ma'am. It's been a journey. And that's why I've started this journey of advocacy because, I just want people to understand that you don't have to go out like that. There's things that you can do. And this is why I'm so excited to talk to Dr. Gab, Dr. Bob, I guess we'll call him Dr. Bob
We're
on.
calling him It's Dr. Bob.
That's
I love
right.
Dr. Bob, and he even has
Good.
a YouTube channel. So make sure you do go and subscribe to his channel. You can
Yes.
subscribe to The Way to My Hearts as well, is at The Way to My Heart for more great
Mhm.
content like this. But Dr. Bob, what's your YouTube channel as well? We are live on your YouTube channel
Mhm.
right now, simulcasting, and it's the at sign. Is it Dr. Bob?
Ask Dr.
Dr.
Bob.
Ask
Ask
Dr.
Dr.
Bob.
Bob. And
Nice.
we are going to be, so stay on the lookout and make sure you do subscribe because towards the end of the summer, probably starting up in the fall, we are going to rekindle the Dr. Bob series and you'll be able to ask Dr. Bob your burning questions about diabetes care. We're really excited, Dr. Bob, having you here. We're coming in on the heels of the American Diabetes Association. Incredible meeting, always impactful. Some year I have to get there, but thankfully you were there and you are
Mhm.
going to share with us over the next hour the critical findings that have come of it. So thank you so much for being here and bringing us up to date.
I'm excited to be here, and it was an amazing meeting of just so much science, so much to impact people's lives, and very encouraging to see the progress being made on many, many fronts.
Mhm. Nice. It's excited to see progress. And I think that's the main thing is that when
Yes.
people, there's been so many areas where it's just been kind of, stasis for many years. But, this is exciting, particularly for the type of condition that it is. Absolutely.
And so, what really stood out to you this year? I'm sure maybe I should go back. What did you go in hoping? Like you had to have had one major agenda item that you said, if I get nothing else out of this event, I want to see this. And then did you see it happen?
Yeah, that's a great question. So, there are several themes that really emerged. One, uh, sort of weight management and the GLP-1s. I think that I was looking forward to seeing the results of several big trials, and pretty much they all turned out the way one would like. So, a whole pipeline of new drugs beyond the two main ones that we already have on the market
Mhm.
that solve some of the issues with what we have now, whether that's a instead of a weekly injection, a tablet a day, to be able to have that kind of weight loss with just taking a tablet,
Mhm.
to adding new hormones to GLP-1, amylin being one of the more exciting ones.
Mhm.
And then the other exciting area were a couple of large trials testing. Um, so one of the issues when people lose weight with the GLP-1 medications is that they also lose some muscle. And that's true of sort of any kind of weight loss. You lose fat and you lose a little bit of muscle.
Mm-hmm.
Um, these are new agents that have the potential to build muscle.
Wow.
Uh, so prevent that muscle breakdown or that muscle loss. And so they could be combined with the GLP-1s to essentially erase the
Negative.
potential problem. And so those were in, late clinical trials and probably will be presented to the FDA within the next year or so. So stay tuned. There was a lot of exciting things in that area.
Wow. I guess for me, I'm hearing a lot of chatter, and I just want to get your opinion on it. Maybe it's too early for us to discuss this, but gene therapy, particularly around a stem cell, stem cell.
Yes.
I know that's kind of that hot topic right now,
Yes.
and I just want to know, I didn't get a chance to go either, but was there a lot of information on it? Was just some information on it? Where are we with that?
Yeah, no, I'm glad you brought that up. That was another one of the big themes. The idea that you can now grow and take someone's blood cell, devolve it into a stem cell, and then grow it into pancreatic islet cells, and then transplant them. And so there were a number of different approaches there. One where with Vertex. Uh, it was a small, about a dozen people, but almost every one of those people got off insulin completely as a result of
Wow.
this. So that's really impressive. This is for people with type 1 diabetes.
Mhm.
The caveat is that they have to be on immunosuppressive therapy, like any other transplant, like a kidney transplant. Uh,
Okay.
but that's the proof of concept. And then there are other efforts to get away from that immunosuppressive therapy to change the stem cells so they're not recognized by the immune system. And so that is also a very promising area. So yeah,
Interesting.
we're getting closer. We're literally getting closer to essentially what could be a cure for type 1 diabetes.
That's awesome.
I mean, that must be music to your ears, Mark.
No, it's an orchestra. It's a symphony. Yes. I mean, you hear so much about it. I've heard a few of the trials, but and you mentioned immunosuppression. So, ooh, you know, what are some of the complications, or has that presented itself? Is anybody and everybody pretty much eligible? When I say eligible, are there any subtypes or any patients that may not be a great fit for this type of therapy? What's some of the guidelines in that regards?
Yeah, and, it's early days. You know, the group that they've studied this on so far are people that are doing very poorly with their diabetes, and they're, getting a lot of really low blood glucoses, ending up in the hospital, that type of thing. So for them, it's worth the risk of being on immunosuppressive drugs because, one really bad low blood glucose, and that could be it, right? And so that's who they've been studying. Um, you know, the downside of the, as you know, the immunosuppressive therapies is that because it suppresses your immune system, you're more likely to get infections of just any kind, and so that can be really problematic. So until they can solve that problem, it's probably not for everybody.
Right.
But they are working on that, and they have some really exciting approaches to get around that, including modifying the genes that are responsible.
Mm.
But
That's
is it something that this therapy would be a long-term therapy, or are they looking like short-term? Because if it's a short-term therapy that it's almost a one and done or two or three, that immuno issue that you're talking about, the immunosuppressant, would be just something that they have to worry about for maybe a short amount of time. But then in the long term, hey, I mean, it's worthwhile maybe staying a little isolated for a bit.
Yeah, unfortunately, that doesn't seem to be the case, particularly for people with type 1. And that's mainly because you have two problems. One, just getting a transplant in general, people need to be on immunosuppressives. But the second problem is type 1 diabetes is an autoimmune disease that destroys those cells. So they still have that process happening different from anybody else. That's how they got diabetes in the first place. So you've got to clamp that down somehow, and that's the second problem that they're trying to solve.
So
I,
what
I,
it's not really a cure, but it's more of it'll be in remission, and to maintain remission, as you do with other autoimmune conditions, you have to maintain the treatment.
For now, yes, but they are looking at alternatives that you would not have to. And one is encapsulating the cells,
Mhm,
putting them in tiny little pouches
mhm, mhm.
that would protect them from the immune system, and then you wouldn't need immunosuppressive therapy.
That's interesting. Hmm. Kind of like pegylation or some sort of encasing of a molecule or something like
Yeah,
that.
exactly. Yeah, yeah. And so, the good thing is you don't need a lot of cells to cure somebody. Pretty much like the size of your thumbnail
Mhm,
is about how much cells
mhm.
it takes to produce all the insulin you need. So volume wise, it's not huge.
Interesting.
So what about detection or was there anything diagnostic wise when it comes, to diabetes? I mean, there are a lot of issues with, when it comes to diabetes that, what came first? Well, insulin resistance, maybe catching, diabetes even before it becomes type 2 diabetes,
Mhm,
let's say. So switching a little bit more from type 1 to type 2,
mhm,
but even in
mhm.
our younger generations, what I was just told recently by a clinician was that they should detect the insulin resistance sooner rather than later, and then they can actually nip things in the bud at a point where everything is truly rectifiable without much effort.
Well, certainly the earlier you can diagnose people, the better.
Mhm,
Um, there is a designation of someone that has pre-diabetes,
mhm,
and their blood glucose is not high enough to say they have diabetes, but it's abnormal.
mhm,
Um, and we already know how to do that. It's a simple blood test, an A1C, to be able to detect that.
mhm.
And yet 80% of the people with pre-diabetes don't know they have it. So there may be more elegant ways to catch people even earlier, but we
Yeah.
know a group of people that need to be screened, and the challenge is really getting them screened.
Interesting, interesting. And I guess that would be my question is where, where would they kind of fit that algorithm? I mean, where, who would they target that will fit that criteria? This is just
Yeah, I mean, so one would be, the recommendations are, and again, this doesn't happen in real life, so this is where we all have to work on it. But starting at age 45, everybody should be screened, and many people at an even younger age. A scary thing is that young people, young adults, are developing type 2 diabetes, which, earlier in my career you would never have heard of. It was not a disease of young people.
mhm.
And the scary part is that young people who develop type 2 diabetes get a more aggressive disease.
Yes.
Um, and so they develop complications quicker.
Mhm,
The treatments don't work as well for them. We don't really understand why,
mhm.
but we've got a big problem ahead if we don't attack that sooner than later.
Yeah, because there was an article that was in Science Direct a couple of years ago, maybe even just a year ago, and they were talking about patients between the ages of 18 and 27 presenting in emergency rooms with advanced stage peripheral artery disease, that poor circulation in the legs, known as critical limb ischemia, pretty much on deck for amputation the moment that they present. And one of the biggest causes is type 2 diabetes that they had had since they were a teen, and it might have gone undiagnosed for years and years and years. And that's really disconcerting to me.
Very, very.
Absolutely.
Was
No,
that something that, and I guess that was probably something that was talked about at the event as well.
mhm.
Yeah, certainly a big concern. Yeah, so we need to do more screening, make it more accessible, And then once you identify people, help them to prevent those things from happening.
I'm just wondering if that should be part of a regular, you know, regimen for even for regular physicals for maybe young people prior to going to college. Say, hey, you're just getting your physical, getting ready to go to school, and that's part of the in the toolkit to
I
evaluate.
feel I've always had my blood sugar checked, not insulin resistance. And I don't know about you. I just maybe it was I was a member of an HMO here in California, and they were all about preventative care, and they
Mhm.
literally ran the gamut of terms of I felt like they were taking half a gallon of blood with every like vial after vial with every single one of my annual physicals clear up, from when I was like 15 or 16 on.
I think that's a one-off.
Really,
Yes, that's
really.
not, yes.
It's not the norm. Oh, wow. I can only share from experience what I went through, but good on Kaiser Permanente then. We'll give them a little shout out
Yes.
for their Thrive program. But yeah, I just have always remembered that it was something that I always worried about eating. I loved my Heath bar crunches. And so I was always worried about eating too many of those and going for my annual physical and if it would reflect in my blood sugar.
Yeah, that's very comprehensive care.
Now you know my weakness. I'm going to end up with an entire box of those things in my nail somehow.
Watch
Something's
out,
going to
yes.
do it. I'm
No.
in trouble.
Okay.
Anyway, thankfully I don't eat any of that anymore. I'm more conscientious, and especially running the Global PAD Association, having so many patients with type 2 diabetes and seeing how it can progress to blocked arteries. I'm a little more careful on my sugar.
Was
So
what's interesting with what you just said, Kym and Dr. Bob, that actually was that actually motivated me to write my book because I had a friend that I spoke last year, matter of fact, and he was telling me, man, my life. I'm thankful to be alive. I was for months. I was in the hospital. I was on acute kidney failure. They had to bring me back. My kidneys. I'm now back to almost 100%. But I went through this whole process. I had no idea that I had type 2 diabetes. I was just having all these symptoms, and then that's where they kind of able to diagnosing from that. But I think it would be great if they can maybe develop some diagnostics that can really pinpoint, at least give sound alarm that something needs to be that you need to be evaluated further.
how about the continuous glucose monitors? So I know a lot of people that are actually picking them up from their local pharmacy. And I'm even thinking of doing it as well. I mean, people who haven't even been diagnosed. And I think that the availability of these types of things are going to be incredibly impactful on helping people to prevent um, diabetes, but also to be able to manage it and reverse the type 2 diabetes sooner rather than later. And I'm curious how maybe they're evolving, at this
Yeah, I
point.
think, yeah, that's a really exciting area as well. They're getting smaller. First of all, two of them are available over the counter now, so you don't. Yeah, there we go. And there's one right there.
That's right.
Uh,
That's right.
yeah, they're super valuable. For people that take insulin, they literally decide on their dose based on that information. Um, but it also gives you a lot of information on uh, the impact of what you eat and physical activity. And so they're available over the counter for people without diabetes who can really help to guide their lifestyle. And then also, useful for people with diabetes. What was interesting is there are a number of sort of startup companies that are developing um, really cheaper and better continuous glucose monitors, ones that could measure multiple other things at the same time. Uh, so one is measuring ketones, and that's probably going to be on the market in another year.
Wow.
Um, but lactate also
Mhm.
for, exercise. And
Mhm.
they have, I mean, these tiny things that are micro needles that you don't even feel them going in, and can measure multiple different analytes. And they say would be really inexpensive to produce. So making it sort of more accessible for more people, because it's a great tool, but not everybody has access to it.
Right. And it's interesting with AI technology now, many of these platforms, of course, AI based, being able to multitask much more efficiently, monitoring and kind of being in the background, keeping an eye on everything going on. That's exciting. And I hope that that continues to progress. But the patients, I think, would definitely benefit from that.
Mhm.
Yeah, to be able to pull all of the data in from different sources, and then give you some information that you can act upon.
Yes. Yes. Yes.
Little nudges.
Yes.
When the box of Heath bars arrives at your home, could take one or two out, but then maybe get rid of the rest.
Or
Don't
punchkis, or pushkis.
tempt me. Any other, you mentioned startups, and I absolutely, the reason I got into what I'm doing is because I'm so passionate about startups. I actually was the founding executive director of a competition with Sir Richard Branson as um, our anchor judge, and I had to help sort through more than 5,000 startups over the course of 3 years, and help figure out
Mhm.
the ones to present to Richard for ultimate investment.
Mhm.
And healthcare was really moving at the speed of light. And there were so many creative companies, and whether or not they actually had any sort of viability,
Mhm.
um, they were still fun to talk about, because I felt like just seeing that there were so many people interested in healthcare
Mhm.
was, as someone who, well, if I ever get something, it's nice to have some hope that people are trying to do something about just about everything. When it
Absolutely.
comes to diabetes, was there anything that really stood out to you, whether or not it's viable? It might be early stage, but it just might have caught your eye, and you might have thought, that's a really good idea. Don't know if it's going to go anywhere, but I really like it.
Mhm.
Yeah, I mean, there was a lot, and it's an area that I'm really very interested in, and so I work with a bunch of different startups, whether that is cell-based therapy that we were talking about, and being able to cure diabetes, to automated insulin delivery devices that could be completely what we would call closed loop, meaning you just put it on and you don't have to do anything. It knows when you're eating, it knows when you're active, and it measures the glucose, and it's like a self-driving car. Those are those are some startups that are getting very close to that, and some of that is driven by uh, patients themselves. There's this movement called "We Are Not Waiting,"
Mhm.
that basically and this started a number of years ago. It was people living with diabetes that essentially hacked into their pumps and their CGMs and started developing algorithms on their own,
Wow.
and sharing it in a community.
Mhm.
And a number of them are quite good, and it pushed industry to have to sort of up its game, and bring something to market quicker. And so those same kind of people are still. I have a couple of patients that
Mhm.
uh, are doing this. It's a little scary,
Mhm.
but they're smart and they know what they're doing. They're software engineers, and they're
Yeah,
figuring it out. They're
absolutely.
like, look, it's a solvable math problem, as far as they're
Absolutely.
concerned.
Now, with these new pumps that are coming out, you say fully these closed loop systems. Explain a little bit more. What does that entail? Because my brother has a pump, and he's
Yeah.
always fiddling around with it. He's always having some issues. It's either kinking or it's something, and he'll have a hypoglycemic episode because it's not give it gave too much, or where are they with that, and what is the
Yeah.
advantage of this particular system?
Yeah, no, thanks for asking that. They're getting a lot better.
Mhm.
The ones that I say, they're three or four of them on the market that are quite good now. And what they do is they take the continuous glucose monitoring data and then deliver insulin based on it. So what they're really good at is overnight bringing your blood glucose to a normal range and keeping it there. Where they're not so good is when you eat, because it needs to know what you're eating to give the right amount of insulin. And so that still depends on the individual to sort of say, I'm eating 45 grams or 30 grams, programming that in and, working with their clinician to figure out that's however many units. The latest one actually lets you only have to say, I'm having a small carbohydrate meal, a medium, or a large.
Mm.
And so you just have to tell it that, and the algorithm then figures it out. But all of this is, as you mentioned, AI, this is all going to get so much better very quickly. These
Yeah.
algorithms are going to get smarter and smarter to do this much more effectively.
And I would imagine that with all of these different technologies that there have to be some studies that are being done along with them. And I'm curious, I've been through the American Diabetes Association's website, and there's a lot to navigate there. I know you're no longer with them, but you are the former chief medical officer there at the organization. Do they have a page with an interactive map to show where all of these studies are being done? Because I think it's so important to democratize access to all of the studies that are available for any particular disease. For example, we have one for PAD that's geared towards patients that we're populating with all of the different ones across the globe. You have Outcomes for Me that's doing that for cancer for patients. And I just think a more informed patient is a better patient, not to say that they have access to these or could even participate, but just the chance, just knowing that they're available, I think is so important.
Absolutely.
Yeah, I think it's a great idea. For type 1 diabetes, Breakthrough Type 1, which used to be the Juvenile Diabetes Research Foundation, they're sort of curating all of the studies that if people want to be part of them. So that's one source for people with type 1 diabetes. Um, there really isn't, unfortunately, and to your point, Kim, there should be something for people that want to be part of clinical trials in type 2 diabetes. There are a lot of them. Just to give you a sense, I was giving a presentation about sort of obesity management and treatment. And right now, there are 300 active trials of obesity medications.
Wow.
So it's a huge, just in that world.
No pun intended.
Yeah. Yeah. So it's really something. So
Yeah.
there is a lot out there, and it would be great to have that all collated to help people.
Mhm.
Interesting.
And yeah, that's incredible. Um, there's something that I want to ask about, and I know it's not your favorite topic, but it seems to be something that is hitting the search engine portals, such as Yahoo and Google and MSN on their news pages, and the diabetes beyond 1 and 2, there's now 3, 4, and 5. And the 5 being the latest one that I just heard about for the malnourished, really in third world countries is what they're targeting. But then there's I don't know what type 4 is, but I think type 3 is they're considering Alzheimer's something. So it really all comes down to, you know, diabetes is a really big problem, and it all comes down to, so much of it comes down to food.
Yeah, and it's, to your point, it's the source of all of these other different diseases, including peripheral arterial
Yeah.
disease for many people. Um, my issue is really just like the naming of like type 3 and 4 and 5. It just sort of gets very confusing for people.
I agree.
That's why I'm not such a fan of that
Yeah.
term.
Yeah.
But people with type 2 diabetes are much higher risk of developing Alzheimer's and dementia, and that is an important thing to call out.
Sure.
So, yes.
Mm. Yeah, that's very interesting. I agree with you. I've seen the different monikers and the different classifications, and it can get confusing. And I think we have to be really clear so people, it's bad enough to try to figure out diabetes in and of itself. And then when you start giving all these classifications, that's
Well, and people are still not sure about the difference between type 1 and type 2,
exactly.
right?
Yeah,
Like that, and that's been around for a long time. So
absolutely.
that's my
And
only
then on top of that,
reticence.
insulin
Yeah,
resistance.
yeah, right.
Exactly. Yeah.
I'm curious, and this is not a political question, and it's just an observation in terms of we're seeing a lot out there in terms of this MAHA movement, Make America Healthy Again, with RFK, his priorities. Let's leave vaccines aside. I know that's a very controversial topic, but it's more about trying to clean up our food and raise awareness of what's in our food, clean up our labels, and whether you agree with the current administration's politics, the movement that we're seeing when it comes to food, I would imagine that ADA, AHA, all of the above would find alignment and opportunities for collaboration and must find some comfort in what's happening with the removal of artificial colors, flavors, etc.
I mean, food is such a critical driver of obesity, of diabetes, of cardiovascular disease. And if you look at the food supply and what's happened over the last, few decades, moving more towards ultra processed food, we know that that is behind a lot of this increase in disease. So
Absolutely.
having some way to address that, I think is would be fantastic. And so that I think there's good alignment that I think we all want people to have access to healthy food, and minimize the amount of unhealthy food. It's sort of a
Yeah.
no-brainer, but that really hasn't been a big effort as of late, right?
Which is interesting how something to me the most simplest is the least
Yeah.
emphasized. I tell people all the time if it doesn't have a seed in it, then
And there is some
eliminate
misconceptions I think that are out there. For example, we just saw with uh, President Donald Trump coming out and saying, "Hey, I had this meeting with the head of Coca-Cola, and they are going to great news. They're going to make it more like what's in Mexico, the authentic cane sugar version without all the artificial sugars." But I really want to make sure. I mean, there's in their statement following that assertion by President Trump, the company in their press release came out and just all they would say was, "Hey, we follow federal guidelines." Well, that's actually disconcerting. Is hey, we align with federal guidelines. Well, you know what? Maybe those federal guidelines do need to change, number one. But number two is even if they do replace it with
Right.
regular sugar, it's
Yeah.
not healthy.
Right.
I don't care if it meets guidelines. I don't care whether you drink the authentic version with cane sugar or not. I mean,
Yeah.
maybe it's healthier. Uh,
Yeah.
it's not healthy.
Right.
So I just want to make sure because I'm seeing all this excitement out there. Woohoo! It's going to be healthier Coca-Cola. Now I can drink it.
yeah,
No, that doesn't mean you can go and pick up soda or that you should pick up soda. We're still having a sugar problem here not only here in the United States, but across the globe.
right.
Yeah.
I imagine that's a soapbox for you.
Yeah, I mean, yeah,
You're an
it's very
endocrinologist by trade.
right, exactly. I mean, it's just very disconcerting that uh people, because of the messaging, it sounds like this is healthy. Whereas you're absolutely right, Kim. It is not healthy. Sugar sweetened beverages are not something we need more of. And in fact, it tracks very closely the increase in obesity in the US, but also globally as we've exported our bad habits.
Yeah, I agree. When you look at some of the other nations that are dealing with, obviously they're heavily influenced by our diet. I think about India and the crisis that's going on there. I mean,
Yeah.
they're really, really, really dealing with this. So many different. I guess I won't even say the early phases because it's just kind of it's really almost epidemic level there, and a lot of it is again it goes back to the diet.
Yeah,
Yeah.
I mean, I agree. I love that even before this administration got in, I think the pressure from RFK to get he took that red dye right head on. And
Yeah.
before he even before the election, we saw that actually be addressed. And so I don't think now we're supposed to have red dye allowed. And even in our meats, it's not even put on. I found out, and I had no idea that they were coloring salmon, they're coloring steak. I mean, it's no
Hot dog.
wonder that, and they're, well, what about hot dogs? It's even remotely.
Even if it wasn't colored, it wouldn't necessarily be
I'm
a good
just,
thing.
just, you know.
Was awesome.
Well,
Yeah,
I think, in many ways the food industry has gone unchecked for, some time
Yeah.
now.
sure.
And we're seeing the consequences. It is it a speaker I listened to recently said, um, you know, wouldn't it be difficult to tell your, great grandchildren that, we had this problem where food became super unhealthy, millions of people ate it, uh, costing society billions of dollars, and then we created a drug that would have them eat less of that bad food, also costing billions of dollars when you could have just not had all the bad food
The
around.
bad food.
Yeah.
Exactly. I mean, just food is everything. And where we
Yeah.
say, hey, shop the perimeter of the supermarket. And that doesn't include, as much as I love the Girl Scouts, the Girl Scout cookies out front. That's not included in the perimeter.
Yeah.
We're talking about whole unprocessed foods, lots of vegetables and everything that's fresh that doesn't have any additional ingredients in it, if at all possible. I know that's less fun,
Yeah.
but
And part of the perverse subsidies and incentives is, it can be it can be expensive for people, and they may not have access to those types of foods. So that's another issue that needs to be addressed.
yeah.
Uh, you know, Subsidies to make high fructose corn syrup cheap uh, are
Right.
not really helping the society.
And they're everywhere, they're place in areas where socioeconomic communities are,
Yeah.
it's amazing how you can go to a store, and if it's organic, if they say organic, I mean, it's twice as much. Anything healthy is expensive, so how are you encouraged to change your diet when they're giving away everything with, with red dye and high fructose corn syrup? They're giving it away for $2, where you go to the grocery store, some of these other stores, it's like $7, $8.
Yeah, I
Yeah,
mean,
the dollar store's filled with them.
Exactly. Yeah, exactly.
Last year I was the American Diabetes Association meeting was in New Orleans, and so before the meeting started, I figured I'd have some snacks available in my hotel room because I knew I'd be there morning till night and coming back late at night to have something. And I looked for like any fruit, uh, could not find it. Even a yogurt, I could not find. There was like nothing. So there are also people that just like live in the middle of a food swamp where you know, there's the cost, but also the access.
Absolutely.
Plenty of beignets.
Yes.
Yes, plenty of beignets. Yes, exactly.
Yeah, that's
Was there
true.
any innovation in food or diet or anything that you saw, any new research aside from that that talked about one of the most popular topics in our network is about carbs, good, bad, ugly. We don't know because you have, the people on some of there are a lot of these grains and such that are actually highly processed. And are they good for you? Are they not? I mean, what's the latest that maybe caught your eye from the
Yeah, well,
ADA?
yeah, it's unfortunate that things are confusing. Uh, I think one thing that everybody agrees on is ultra processed food is not healthy, and so avoiding that. So to your point, you know, shopping the perimeter of the supermarket,
Yeah,
having
absolutely.
fresh vegetables, all of that. I think that's quite clear. Fiber is good for you. Uh,
Absolutely.
in terms of carbohydrates versus fat, you know, for most people, it's an issue that they're trying to lose weight. And I think it's when you compare a high fat versus a high carbohydrate diet against each other, or low fat versus low carbohydrate, and you take 1,000 people in one group and 1,000 in the other, you don't see much of a difference.
Mhm.
And the reality is that everybody's a little bit different. And for some people, one is going to be more effective at the other in terms of losing weight, whether it's a low fat diet or a low carbohydrate diet. What I typically ask my patients when we're talking about, having them try to lose weight is, have you ever been successful in losing weight? Because everybody's tried, and many people have been at various times. I'm like, so what did you do? And that's probably what works for them. And then it's taking the marathon approach. It's not a sprint, right? Because you've got to change your meal, your meal composition long term, not just for a month.
Yeah.
We just had this gentleman that we interviewed. He was in our network. His name was Jose, and he found us 3 years ago through our network on the Global PAD Association because he was having leg pain and he ended up with peripheral vascular disease, both
Mm,
arteries and veins impacted.
mm,
We tried really, really hard to get him to a vascular, but every vascular said, you know what, we'd love to treat him, but he's 600 pounds and there's no table that will support him. He must lose weight and we will treat him. In the meantime, let's try conservative methods, medicine,
mm.
exercise. And he ended up with, from the first post where he asked about people's experience with cold feet to now, he's lost 300 pounds. Literally, he picked up
So,
a book online from a
yes.
former resident that specialized in nutritional, um, culinary nutrition, and who's now actually a family medicine doctor.
Mm.
And he just started following it day to day to day, doing the treadmill, everything.
Wow.
And he now, I mean, 300 pounds, it's so amazing. And he has no more symptoms
Yeah.
from PAD or chronic venous insufficiency. He said his legs feel great. He's taken the pressure off of him. And so it's really powerful, this weight loss. But I think his situation, it's what worked for him. He didn't want to do the medications they kept offering him because he saw the side effects and there were a lot of things he just wasn't comfortable with.
Mhm.
He was told about the keto diet. He tried that. He was told about all these things. And he just said, you know what? I got to do what works for me. The only diet that really works is one that you stick to.
Yeah, that's interesting. Yeah, that's
So
post. That was really amazing. And it's very encouraging, pretty much to anyone. Where are you in your you know in your condition? A lot of times people that they're so depressed because they feel that their situation is hopeless, and it's always good to hear those types of stories to help encourage people that, that the only mistake you can make is doing that.
yep. So, but it's really about just getting started and just knowing what's out there and choosing, what's right for you. But Dr. Bob, we really appreciate you joining us. Is there anything as we close out here that we missed in terms of exciting news and revelations when it comes to diabetes care? And what are we looking forward to over the next year? Or what do you hope to see over the next year,
Mhm.
before the next meeting?
Maybe I'll just give one other study that I thought was really encouraging, and this was sort of the broader study results of the STRIDE trial that was in people with
You're
PAD.
speaking my language. I
Yes,
love
yes.
it, Dr. I think it's Dr. Bonico or Banaka
Yes.
out of
So a,
Colorado.
a, a large trial that used a GLP-1
Mhm.
in people with earlier PAD that had claudication, so they had pain on walking. And the idea was, could you medically treat them? Because there really aren't, really particularly effective medical therapies for this.
Mhm.
Uh, Half the people in the study had diabetes,
Mhm.
so it really speaks to the world of diabetes.
Absolutely.
There was a significant improvement in the maximal distance that they could walk,
Mhm.
which really sort of translates. Heard some interviews with patients of you know just being able to walk to the mailbox in a rural area. Well, that's a life-changing thing. That makes a difference in their life, a quality of life. They all sort of improved quality of life wise, and so um, um, there's now medical therapy along with the other great surgical kinds of approaches that one can do for PAD, and so that I think that's quite exciting.
Fantastic. Any last words, Mark? Any last questions before we wrap up this amazing interview with Dr. Bob? So thankful that he joined us today. So I
Absolutely.
learned so much.
No, the only final comments is it's good to hear movement in the space. As a patient, it's exciting to hear new technology and new therapies that are in development. That's always encouraging for any patient, particularly one that is type 1 like myself.
Thank you, Dr. Bob, for being here. Thank you to my co-host, Dr. Is a perfusionist? Is that a doctor?
No, no, we
No,
are people
so
specialists.
cardio perfusionist and
We are,
author
that's
and
right.
type 1 patient,
That's right.
Mark Brezell.
Extraordinaire.
And thank you so much for being here. Make sure you like this video and subscribe to our channels. Ask Dr. Bob. Again, be ready for a new series of Ask Dr. Bob where he's going to be answering your burning questions starting this fall. So make sure you subscribe to his channel on YouTube, youtube.com/the @ Ask Dr. Bob. And don't forget to subscribe to our Diabetes and PAD podcast at The Way to My Heart. That is youtube.com/the @ The Way to My Heart. Have